Good evening. Welcome to this Crohn's and Colitis UK Q&A live. I'm Isabel Mason. I'm a nurse consultant in gastroenterology at the Royal Free Hospital. I also work for Crohn's and Colitis UK, running their nursing strategy. And with me is...
Hi, my name's Charlie Murray. I'm Clinical Director for Gastroenterology at the Royal Free Hospital in London, and I'm the IBD lead here as well.
Thanks, Charlie. And actually, we're very sensibly self-distancing. If you knew where we were geographically, we're both in the Royal Free Hospital, about 15 metres apart, but following sensible self-distancing rules, which means we're in separate offices. Charlie, I just thought what we'll do, if it's all right, is just have a conversation to start with, just
Sure.
about what's going on in terms of COVID and services. But also then we've got a few questions that the comms team at Crohn's and Colitis UK have already gathered for us. And hopefully people watching at home will send in some questions so we can answer some questions later on. Is that all right with you?
Yeah, no, I'll be very, very happy to do that.
Yeah.
Go on. You're going to ask me a question.
Yeah, I was going to say, there's been lots of changes, hasn't there, for us? And one of the things is that you're on call today, aren't you? You're actually working in the hospital.
I'm actually wearing blue scrubs. So, yeah, I mean, I can talk about the whole journey, if you like, that's happening at the Royal Free. Now, as all of you will be aware that are watching, things are very different in different places in the UK, and we know that. So mine's very much a personal experience of being in North London, basically. But the Royal Free took a decision very early on in the COVID-19 pandemic to essentially disband the specialities. So, and I'll get back to that in a minute, because it didn't mean we didn't do the work, but it meant that people like me as a consultant physician and gastroenterologist had to join the COVID on-call team, so of which I'm still on. So we went from consultants doing our IBD clinics and our endoscopy list to essentially being on a day and night rota for COVID on call. So we were seeing COVID patients in casualty and admitting them to hospital, looking after them on the ward. And people like Isabel, with me here today, have been up to ITU. So we've all been devolved and disbanded in certain ways and redeployed certain parts of the hospital. But obviously go on.
And we reflect, don't we, what's going on all over the country. So wherever you have people listening are having their IBD care, really a lot of us have had to be working in other areas, managing and keeping the IBD services going, but at the same time supporting what's really been a busy time.
It has. And actually what that meant was that really at great speed, we had to reevaluate how we were going to make sure that the IBD service as well looked after, didn't we, Isabel? And that was a massive team effort between nurses, administration and medical staff like myself. And actually everyone's come together really well. Now, everyone does things slightly differently. So I'm sure if there are questions, things are done differently in other trusts. But essentially what we managed to do is that everyone took a role, everyone put some hard work in. We've continued to run our advice line. We've continued all of our clinics actually, but we've converted them all into telephone clinics, which has worked really well and it's given us something to ponder on for the future. We've had the availability of a flare clinic every week as well to make sure that if people really are sick, we can try and avoid them having to come through A&E. And that's worked really well as well. And actually, it's given us a lot to think about. And I'm sure you guys watching about how we then manage outpatient monitoring and whether or not we need to stick with the model which we currently have, as anyone from the Royal Free will know, of having huge multidisciplinary clinics that are very busy and often run over. And actually, we've learned a lot from this. But it's had some very particular challenges, which I'm sure we'll talk about.
Yeah, and certainly from the nursing end, because I know IBD nurse specialists are often really fundamental. You know, we have done exactly the same. We've managed, whilst nurses are working in intensive care or they're working in endoscopy or in other areas of practice, we've managed to get enough support going, and that's really been down to the flexibility locally. And just those brilliant nurses, the team have been great, haven't they? Charlie, there's also been some national conversation, hasn't there? Because I know you've been involved with the British Society of Gastroenterology, really with teams across the UK having exactly these conversations, but doing it together.
So, yeah, exactly. So very early on, and this is something we've never done, certainly not at such speed and with such communication, we formed a UK IBD COVID-19 group, which is a snappy title for a WhatsApp group, and mainly initially on WhatsApp and then via Microsoft Teams, which we all seem to be using now in the NHS. We very rapidly, with a back and forth, started formulating ideas and guidance about service provision, but also about something else which will be very close to all of you, which is the guidance for things like shielding and vulnerability of patients during this time. So that was a huge amount of work done very quickly, which actually got ahead of a lot of the other specialities, I think, in doing so. And in fact, what essentially began as a WhatsApp chat and then much more in-depth meetings offline, if you like, with various of us, became a publication in Guts, in the journal Guts, which really formulated what then became the amazing guidance from Crohn's and Colitis UK in terms of
and so it's been a real together, hasn't it, approach that, you know, now there's guidance for hospital teams about how they should be running their services, doing this juggling act that we've talked about, but also that links to the really invaluable information that's on the Crohn's and Colitis UK website, because without that, I mean, we've just been signposting everyone there, has all the important information about COVID-19 and about IBD that people need.
No, I couldn't agree more. And that's been, I think sometimes when you're involved in creating what essentially is a grid and a long document which explains things in a slightly wordy way, when you see what Crohn's and Colitis UK did in order to get that much more usable and user-friendly, was really quite amazing, and it helped us out enormously in the weeks following that.
It really did. In those first few weeks when people were really anxious and frightened, it was just an invaluable resource. Can I just talk a little bit more in depth about the things that commonly are changing in hospitals? And of course, we're using ours as an example, but as we've said, hopefully other hospitals are following the same messaging that we are. Just talk a little bit, Charlie, about biologic therapies and infusions, because lots of people listening will be people who'll be coming to hospital for infusions or are having treatments at home. Are we advising people to carry on with those?
Yeah, so certainly. So there's been a lot of discussion in the UK, certainly in our group, about this, but also this is a very live and very quick discussion of the outbreak of this done internationally, which we're all involved in. So I'll be reassured that there's a good international consensus on this now. The bottom line is that there are several risk factors in treatment with for Crohn's disease that we try and avoid. And the biggest thing Crohn's and colitis, sorry, that we try and avoid. And the biggest thing is becoming unwell if we can. So we don't advise that people stop their treatments. And actually, for all of the biologics, generally, we do suggest that people continue on them because stable disease keeps you safe. And if you're well, then that decreases your risk of subsequent infection and subsequent severity of infection.
And what is it about having a flare that puts you more at risk?
Well, you start from, apart from anything else, you start from a lower baseline. If you are unwell, which is associated, with a big inflammatory response, then your ability to fight a further big inflammatory response, and COVID is an incredibly inflammatory infection, is decreased, and you're more susceptible to that illness.
So really, if you've got inflammation in your body and your body's already dealing with that stuff, and then you get a really big big virus, which then puts all that extra pressure, it's more difficult for your body to deal with it.
Well, yeah, I mean, as you know, it's more complex than that, but essentially that's what we're talking about, yes.
Okay. And so what should we be saying to people? The first thing that strikes me, beyond biologics, what are the other things to say about how do you keep yourself well? How do you stop getting a flare?
Well, the first thing to do is not just stop your medication, because we know that can be the knee-jerk reaction to any concern about infection, which this obviously is on a big scale. The second thing is to take advice about social distancing, not touching your face, washing your hands, all the things that we've heard repeated many times, but are very important for those on their medications. Yeah. And from a flare point of view, although it's slightly, if you like, softer evidence, is just looking after yourself, being kind to yourself during this time. It's a very stressful time. It's not a time to put undue stress on yourself either.
Yeah. And what do we know, or what information or scientific data is there about Crohn's and colitis and COVID and its impacts elsewhere. Are we learning anything from the Chinese, from the Italians?
Yeah.
Do we know any more?
So we're getting information and data all of the time. So the first thing to say is that there is it's called the Secure IBD Registry, which is based in the States, but actually is international, which is a repository of data for any recorded COVID positive IBD patients, which we have fed in for the Royal Free and others in the UK. And that makes very interesting reading. Generally speaking, IBD patients don't seem to have been unduly affected by COVID, or certainly not in the small numbers we have so far, but there's clearly lots more data to collect, and we're actually doing that nationally at the moment. So we're doing that on a national level in the UK through our group, through the BSG, and we're doing that internationally through the IOIBD as well in terms of their registry. So just to summarize that, people don't seem to be at a huge amount more risk. We think that if people are having flares of their disease or are unwell generally, then that may be a risk factor. We think that the use of high dose steroids we should try and avoid where we can. That seems to be coming out as well as a risk factor as well. And to try and get down below 20 milligrams of prednisolone, for example. But what is not coming out is any huge signal suggesting that being on a biologic or any medication like that is an adverse outcome risk factor.
Okay, so that kind of brings us to the messaging, which is that most people, if they have Crohn's or they have colitis and they get COVID, will recover, I assume.
Yeah, that's exactly what the experience is so far.
Positive message that actually outcomes for people with Crohn's and colitis are usually good, but there are very clear things that mean that you could be at extra risk and that you need to take sensible precautions about.
Yeah, that's a good summary, Isabel. Yeah, I agree with that.
And so then when we look at those, and I know there's a really good decision tree for people to go and work out their own risk on the Crohn's and Colitis UK website, but the big themes about risk, Charlie, are medication is important. Is that right?
Yeah. So
and you particularly said steroids are beyond almost any of the other medications that we regularly use in Crohn's and colitis. High dose or reasonably high dose steroids are the ones that we want to avoid.
Yeah, so to be clear, because it's confusing, lots of people have to use steroids at some point or another. This is high dose that we would rather avoid if we have to. The caveat to that is there will be occasions where high dose steroids need to be used, certainly in the hospital setting. But if we can get you off steroids, then we should try and get you to a lower dose. Just something to mention at this point, that budesonide as an oral steroid does not seem to confer the same amounts of risk. So we don't have the same concerns about that as a medication. But certainly above all of the other medications we use commonly in inflammatory bowel disease, prednisolone or high dose steroids are the ones that we would like to decrease or hopefully get people off.
So if you're on over 20 milligrams of prednisolone as a tablet every day, then that probably means you've got an extra risk. Is that right?
Yes, that's right. I mean, everyone's an individual, but if you took everyone together, that would be a risk factor.
Okay. And then we've already established before that if your Crohn's or your colitis is flaring, so your bowel isn't well controlled, that because of this issue about a second lot of inflammatory process, a second lot of illness, that probably increases your risk too.
Yeah, I think that's fair.
Okay. And then there's something about age, is there, in terms that's been one of the big conversations about, they use this 70 line, over 70s probably have a bigger risk than younger people?
Yeah, so if you look at all of the data for COVID generally, then most certainly older people are more at risk of serious disease. Okay, so it doesn't mean that we don't all get infected, because any age group can become infected. And indeed, sometimes younger people do get infected and do become very unwell, but that's relatively rare. Yeah. And we tend to see bigger groups in the over 50s that have multiple comorbidities, and in older patients as well. So that is something.
And that's important. So a comorbidity means another illness that you're living with.
I'm sorry, yes. So for example, most commonly we see people with who may be older in age, have diabetes, high blood pressure, and other illnesses.
And sometimes it's a combination of those things, I'm assuming, that then puts you in the more vulnerable category. So if you're older and your bowel's not very good and you've got a history of blood pressure, those are the things that sort of start saying that you may be in the vulnerable group. Is that right?
That's exactly right. That sort of moves you. So that moves you from a situation potentially where you may just have to social distance like everyone does, albeit stringently, to actually having to think about shielding within the home.
Okay, and we'll talk about shielding and safe distancing as we go through. But like I said before, there's a really good decision tree on the website, and people can go and just do their own checkout and just see what the implications of those different groups are for them as individuals. We talked about biologics, we talked about steroids. What about people who are on immunosuppressants that aren't biologics, so tablets like azathioprine, mercaptopurine, methotrexate? What implications does that have?
In terms of being on the therapies, we still wouldn't advise people to stop those therapies. Okay,
Right.
there is a particular, I guess, a bit of advice if one were to get COVID infection, and that would be, although it probably doesn't make much difference, we tend to tell people to withdraw their medication for the period in which they are unwell, and then to restart afterwards.
And when you say unwell, does that mean unwell with a bit of a cough at home, or unwell with a temperature, or unwell in hospital?
No, so it's any of those things. So if there's any suggestion that you have symptoms compatible with COVID for that 2-week period, you should come off those medications.
Okay. And then the other big group of medicines are mesalazines or 5-ASAs, so people will know them as Octasa or Asacol, and any risks or
so
worries
we
around
have
those?
Identified no worries and no risks around them, and actually they're very safe drugs, and they certainly don't need to be stopped.
Okay. So if you feel like you're becoming unwell, if people are at home and they feel like their bowel is beginning to play up, following all their advice that they get when they talk to their teams, the most important thing is to step up those treatments, get the treatments going well, and contact the team. Is that really the best advice, do we think?
No, that's absolutely right. Now, hopefully, many people have had these discussions before about modifying their medications and about patients taking control of their medications to a certain extent, certainly with mesalazine. So many people will be able to do that on their own because they know their bodies, know how things work, and know what they need. I think if you are having problems with your IBD, it's really important that you contact your IBD team during this time just to get advice on how you can make small changes to have big effects without putting yourself at any risk.
Yeah.
For example, you can't modify, as I'm sure everyone knows, you can't modify immunomodulators yourself and things like that.
Yeah.
You should not do that.
Yeah, so and we certainly here in our service, and we're probably quite typical, we give very clear information to people about what to do when they're unwell, but also they can still contact us. Things have changed a little bit, so even if you're at home and you're well, you might want to just listen to the message that's on your nurse's voicemail, just hear what it is, because things will change a little bit as time goes on. Services are coping, but you can still get to us, and we still have a face-to-face clinic, a clinic where people can come if they're sick and they need to see a gastroenterologist, don't we?
That's absolutely right. So another real take-home message from our discussion this evening is that one thing, going back to the beginning of our discussion, one thing I see today in A&E is that the non-COVID infection admissions to hospital have dramatically decreased. Okay, so the emergency department, now that the COVID admissions are going down, is the least busy it has been in a generation. And that tells us that, well, it could tell us many things, but one of the things it probably tells us is that there are people that are unwell that are staying away from hospital and staying away because they're scared about COVID. And the bottom line is, and just to make the point that yes, contact your nurse specialist, yes, contact your IBD team. But if you are very unwell with your inflammatory bowel disease to the extent that you would normally go to hospital, then you shouldn't be delaying that because of the current outbreak. There are ways we will deal with that when we see you.
Yeah, there's a really clear message, and actually it's not just related to IBD, but that the NHS is still open, isn't it? That
Yeah.
if you're unwell and there are things that you would have gone to hospital for, you might want to use 111, you might want to have a conversation, but if you need us in an emergency, we are all still open and here.
Absolutely right.
Okay. One of the questions that patients have started to ask us now is, as there's conversation about a vaccine and, you know, it's moving apace, the development of a vaccine for COVID, what will be the implications for them if they're on immunosuppression, if they've got a suppressed immune system from their treatment for Crohn's and colitis, about whether they'll be able to have a vaccine?
Well, answering that, so the first thing to say is, as you know, I'm sure, we're nowhere near having a vaccine yet. They're just in studies, and the first human study, I think, starting this week in Oxford, but that doesn't mean the vaccine will be available soon. In terms of vaccine, remember, it's a coronavirus, and a bit like with the influenza outbreaks, when vaccines have been produced, we do recommend people on immunosuppression have them. We don't know yet what being on immunosuppressive drugs will have, and what effect it will have on the vaccine in terms of the development of antibodies, even when produced. But the aim would be to get a non-live vaccine produced, because actually the fact that we're having to recommend that people on immunosuppression do look after themselves more and shield and distance more than the rest of the country, which I'm sure we'll talk about even more, means that any vaccine has to confer protection to that group of patients. So I'm sure that's what I'm not working on it myself, but I'm sure that's what we're looking at. Also, specifically because of that question, certainly in the UK, we will try and look at that in advance. So responses to any sort of vaccine development and its response to subsequent vaccine of IBD patients will be right on the top of the research agenda.
So if I just kind of summarize that in my language, that what you're saying is any vaccine will be a way off, that just like flu and the fact that people who are on immunosuppression for Crohn's or colitis are advised to have a flu vaccine, the chances are it will aim to be a non-live vaccine and they will be advised to have it. Is that what you're saying?
That would be my assumption, but I can't say this time.
It's early days. Okay. Yeah, and again, it's a really good reason to keep an eye on the charity's website. They're updating the information really regularly. So as this stuff moves through and develops, you'll hear it first through Crohn's and Colitis UK. It's really good. Finishing off really is about routine stuff, Charlie. So, there are people who are expecting to have an annual colonoscopy or expecting to have a 3-monthly blood test, where now everything, only in the last 6 weeks, but everything is different. What advice are we giving now in terms of routine surveillance, whether that's blood testing or endoscopy now?
Okay, so the first thing is that we work with endoscopy first, the majority of endoscopies can be delayed. It's certainly for surveillance. Okay. So, and we would delay them for several months to get out of the peak of what is happening at the moment. So, as many of you will be aware, you've had contact with your services, actually endoscopy services, even today, are for the most part on a routine setting, being stepped down completely across the country. So that we don't have it as an availability. But we will do in the future, and they can safely be delayed. We have looked as much as we can in many units, and again with UK IBD COVID group, to maintain the use of fecal calprotectins. Many units are starting to use point of care fecal calprotectins, which can be used at the point of care, which makes things even easier. And it may actually be one of those things that pushes a change in practice, that we're doing less endoscopy and more non-invasive markers of inflammation.
So to summarise that it really, don't be too concerned if you have a once a year colonoscopy and it's postponed. There's nothing majorly to be concerned about that with. Agreed. But also it's worth having a conversation about whether one of these poo tests, these taking a sample fecal calprotectin tests, which give us a sense and give you a sense of how active the inflammation in your gut is, whether that's an alternative that can be used without then having to have endoscopy, which currently is closed.
Yeah, I'd agree with that exactly. And then the main thing is, then we come back to, actually, I didn't really answer the question about biologics earlier. As a unit here, we have not, for example, looked at increasing the time between infusions for various biologics. There are reasons why we haven't done that, mainly because we worry about people flaring and we worry about increased immunogenicity, development of antibodies against the drug, so you may lose effect. And actually, the best thing is that units find a safe area for those infusions to be given. The reason I mentioned them with the blood test question is obviously we were planning to do bloods only at the time of the infusion if you're having an infusion medication. Okay. If you're on a subcutaneous biologic medication or an oral immunomodulator like azathioprine or methotrexate, if you are established on those medications, the benefit of taking exactly 3-month tests are outweighed by the benefit of not being exposed to COVID virus in a hospital setting. So I would suggest, in fact, most of the commissioning groups actually have got their own guidelines on this now, and certainly ours locally have. But we would also agree that, for example, if you had a 3-monthly azathioprine blood test, we would be very happy for you to stretch out to 6 months, for example, if you were stable and on a stable dose.
So really, if you're going through infusions, then they can do their blood test monitoring when they stick the needle in your arm for that.
Yeah.
And that if you're having home injections or home tablets or medications that need 3 monthly, if it stretches out a little bit, the prescription should keep coming. It's not a big, and probably it's better for you just to stay home. Don't come to the hospital to the blood test room, and just say, okay, I'm going to miss one blood test.
That's exactly right.
Okay.
And we will always support all patients with GPs, and the commissioning groups are open to that too.
I know you had a meeting with our lovely colorectal surgeons here yesterday. There will be also people out there who are waiting for operations or are worried that operations that they think are quite urgent are being postponed. Where do you think we are in terms of getting back to operations again?
So I think that's really difficult. But I think working backwards again, if you have an urgent operation which needs doing acutely, so a burst abscess or a peritonitis or something awful that happens very suddenly, that will always be done. Okay. So you don't lie at home suffering thinking no one will look after you, because if it needs to be done, it will be done on the admission at the time you're in hospital. Okay. If these are semi-elective procedures, there is a complication around contracting COVID around the time of surgery, actually, which could be really quite serious. And for that reason, we will try everything we can to delay the point of that surgery. So that's what may be happening.
So what you mean is, if you're having an operation which isn't urgent, it may be that you feel you need to have it done soon, but there is something about the risk of coming into a hospital with all the problems and all the infection that are currently in hospitals, that means that actually it's better to talk to your team and see if you can work out a plan of action to delay it as long as you can.
That's really well summarised. That's exactly right.
Okay.
Yeah, it's exactly right. But in terms of when, because I'm obviously skirting around the problem, so I can tell you that at the Royal Free today, we've had a massive, I'm going to guess 70% decrease in COVID numbers through the door. Our wards are emptying a bit. It feels like we could all get back to work tomorrow. What we don't know, and you will have seen on the news 100 times, I'm sure, is we don't know what will happen when we do start less social distancing, because clearly what we're seeing now is the effects of effective social distancing around London, with less people getting infected. Now, what we don't know is whether we'll bounce back up again. So we hope we're at the slow beginning of bringing our elective surgery and our elective endoscopy and our elective face-to-face outpatients back, but it will be a gradual process.
Okay. No, that's really clear. It's really clear. And like you say, in some ways, people with Crohn's and colitis, whilst there are very specifics that we're talking about, aren't there? You know, specific things around medication, specific things around services. Actually, the messaging that comes out from Public Health England and through the scientists, through the government, actually, they're just all things that everyone should be listening to anyway.
Yeah.
Okay.
True.
Good. I think that's my list of things that we were going to talk through.
Okay.
there are a few questions here that already we'd had in advance. This one can follow on actually, and I'll give this one, some of them I'll do, but this one I'm going to give to you because it follows on from the last one. So I had surgery a few weeks ago. Does that increase my risk?
So having had surgery a few weeks ago probably doesn't increase your risk. The risk is at the time of surgery, actually. So if you're at home and you have recovered, then your risk from having been exposed, I mean, it was 3 weeks ago, so you're outside the incubation period of the COVID virus. So actually your risk will return to baseline.
Okay.
There is a big risk around the point of surgery, and there is a risk in a couple of weeks thereafter if you were to contract the virus.
But that risk isn't because of your Crohn's or your colitis or because of your operation. It's just because you've been in a hospital.
Yes.
Okay. And any extra risk for people living with stomas or pouches?
So we haven't found any increase in risk for the two groups of patients, except in the instance where people have very active and difficult to control pouchitis or complications. But a stoma per se is not an extra risk factor.
So the same vulnerabilities that are on the decision tree, you know, that if your bowel isn't behaving well, if it feels like you've got active inflammation, even if you're living with a pouch, that's the same rule as if you didn't have a pouch, presumably.
It is, yeah.
Okay, no, that's clear. I'll answer this one because I know this one's one I hear all the time, which is people have been sent letters telling them they're in the vulnerable group, and the vulnerable group have been told to shield, which essentially means you have to stay home. Currently, shielding means staying home for 12 weeks. But actually their team have said, no, we don't think you are. And the question is, what should I do? My answer to that is you need, and Charlie, correct me if I'm wrong, but you need to go and absolutely use the Crohn's Colitis UK website, use the decision tree, follow the advice from the IBD team. The government have been sending out, and local health authorities have been sending out letters blanketly to people on certain medications, saying that they're in the vulnerable group. And that actually, when we look particularly at IBD and all that work that we've talked about, that we've done really identifying it, actually it may be that you're not in that group. And it's really important for your mental health, for your life, for your everything, that you, if you're not in that group, that you realise you don't need to stay home for 12 weeks. So go and have a look at the decision tree and use that as the guide rather than a letter you get through the post, I think.
I completely agree.
Nothing controversial in that?
No, there's nothing controversial. I mean, there are reasons behind that, which I don't think we need to go into why that has happened. With all the best will in the world, everyone was trying to protect everyone. But things went at different times, and I think it's become confusing. But what I can reassure and back up exactly what you just said, a huge amount of work went in nationally to developing the grid and the risk categories in IBD, and I have been very reassured by the excellent tool.
So I'm getting things on my phone now. They're kindly sending me through questions. So this is from Sophie, and I think there's been lots of questions about it really, which is, what happens after 12 weeks? So if you're in the vulnerable group, you've been told 12 weeks, what's going to happen after that?
Really good question. So the 12 weeks was a blanket because it seemed that the hope would be that we'd be over the worst in 12 weeks and that we wouldn't have a lot of viral infection around. I mean, essentially, I'm sure what will happen after 12 weeks is a bit like you're seeing with the government response for social distancing, which is that will continue. I think if you've had a 12-week period and the peak of the infection is gone, it is highly likely that you won't be asked to be in lockdown quarantine because that would be too much, but you will be asked to socially distance in the same way. And actually, we will carry on doing that as well within the hospital environment because we will have to social distance our infusions. We'll have to change the way we do endoscopies in terms of socially distancing patients.
Yeah. There's a second kind of question that comes on still from saying, how can I social distance when I come in for my infusion? All I can say here is we have moved our infusion unit to an area of the hospital. It is still in the building, but it is their individual rooms. So people are socially distanced. They're not close to one another. Clearly, you will have nurses phlebotomists, pharmacists around, but they'll all be in their standard protective, wearing their standard protective equipment. And so actually we're managing infusions as well as we can to keep social distances reasonably good. Is that fair, Charlie?
It's completely fair, and you'll hear stories of other units doing very similar things, or taking, within London, certainly using other completely different units where social distancing can be maintained.
Yeah, and in fact, it's one of the interesting conversations you're having, aren't you, about endoscopy and how we're going to manage endoscopy keeping social distance, isn't it?
Very much, which is very challenging.
Yeah. Another question. I've advised that my infusion may not go ahead next time as the specialist nurses have been sent elsewhere. What are the risks of a break in infliximab infusions, particularly then when you restart? What's the chance of building up antibodies or the chance of it no longer working?
That's a very difficult question to get me in trouble on Facebook there. It's a great question. It's a great question. It's a great question. So we know from all the studies before, certainly if you get to around, I mean, it's just from trial data, but if you get over 14 weeks between infusions, your chance of increasing antibodies does definitely increase. So if it's going to be delayed by,
just say the week 14
weeks or above that, but that's a long gap. That's essentially almost, not quite, but almost two infusions worth of gap. So we know the longer you leave it, the bigger chance of antibodies. But we also know that the developing antibodies from, for example, week 8 and between that period, the uplift in antibody development is not that large. Okay, so that's one thing. Second thing, the risk of you flaring is really an individual thing, and we all know, and I'm sure there are people watching who know full well that at week 7 or week 9, if they miss their infusion, they will start flaring.
Or as they get up to their infusion, they
exactly. So, and if you're one of those unlucky people, then delaying your infusion is not good for you. If you are entirely stable, and everyone would suggest that it is only entirely stable people that should be having their infusions delayed, ideally. You know, I know it's difficult for the local institutions, but ideally, then the risk is probably very small in delaying for a few weeks. But as the longer you go, the more the chance of antibodies.
So there is some reassuring message, which is, like we explained at the beginning, hospitals are managing massive change. And if you're stable on infliximab on an infusion and it's delayed by a week or two, really don't be too worried.
Exactly.
There is something about 14 weeks, and there is something about your stability that might make you want to have contact and talk about it more. But it may be that there are people where for short periods of time things are being postponed.
Yeah, true.
Okay. Another question. I think I'll do this one. What's the difference between social distancing and shielding? And that's really coming back to the decision tree and where you are in your risk. So if you're in the high risk group, the government advice currently is that you then go into the shielding category, which means for this 12 weeks that we talked about, you really shouldn't leave your home. You should stay indoors, and there are lots of support and options out there in terms of getting shopping in for you, getting, keeping contacts, the NHS volunteers, calling, and you can actually self-register as someone who needs to be in the shielding group through the Crohn's and Colitis UK website. If you're in the moderate group, then that's what you talked about before, Charlie, which is about doing the sensible self-distancing things. So only out for walking or essential shopping, keeping 2 meters apart, using tissues, washing your hands, really important. In fact, we were talking today in the hospital about how it feels like the social distancing, that the impact of the social distancing before the lockdown was already happening. Actually, it's as important as the lockdown, almost, the social distancing. So go to the decision tree, work out which group you're in, and then follow the advice based on those. It is interesting, isn't it? Definitely in London, we see a lot of people around. It still feels like there's quite a lot going on in cities, and people who are living in flats or areas where actually there's not much choice but to go out. It's not easy, is it? And it's important that people get themselves in the right group.
Yeah, I agree. Yeah.
I know. I thought you'd just say that. There you are. Okay, I'm going to give you one now. So next one is, I'm newly diagnosed, but I can't get an appointment to start treatment. What should I do?
Well, as we said at the beginning, it's difficult because obviously local circumstances are always different, but the NHS is open. And for newly diagnosed IBD, there should always be a way through the GP to getting into hospital to be seen. So I would ask the GP, albeit remotely potentially, who can push for you with the local services. And I guess I don't know, Isabel, whether, you know, through the charity, there's always help with local support groups as well for those areas about how you might be able to access care.
Yeah, so there is a map on the charity website for contacts to IBD services, so the nursing contacts. So you can go into the charity website, put in your postcodes, and it will give you the contacts in your local hospital. I think it's still that same message that you had before, though, Charlie, which is that the NHS is still open. And that if you can't get the treatment that you want, you just go through the same routes that you would have done before. So back to your GP, and then if you're really concerned you're unwell, A&E is still there. You know, we're still available for that, aren't we?
It's exactly where I'm going after this.
Lucky man. I'm aware of the time. We've got
lucky.
3 minutes. I'm going to give you one more question because this is good for you, because you do some adolescent stuff, don't you? Does the decision tree apply for children as well?
So yeah, that wasn't for the decision tree, or at least our discussion wasn't specifically around adolescents, but the same key messages will apply. Yes.
Okay, good. I'm aware we're running out of time, and you have got to go back and do some work. Not that I'm suggesting you're not doing any work now. Yeah. The broadcast will stay on for everybody. The broadcast will stay on the Facebook page. Charlie, if you're up for it and this is popular, we may offer more if that's okay. And
I'll be fine with that as well. Yeah.
Good man. And then I want to finish off just with saying, you know, as healthcare professionals, we are so supported by Crohn's and Colitis UK. Really, we couldn't have dealt with the level of anxiety and questions and need for support and information without the charity's just amazing work. Because of the closure of particularly of fundraising activities, they're really, you know, it's had a massive impact on their income. So if this has been useful and you really value what the charity is doing, please look at your membership, think about a cash donation, because we really value it, don't we?
We absolutely do. No, we couldn't do many of the things that, certainly from the support point of view, Crohn's and Colitis UK are priceless to us. So we need to keep supporting them. Priceless
is the word.
Priceless.
Thank you, Charlie. That's it. We're at 6:30, so that's our finish time. Good luck for the rest of the day. And at 8 o'clock, they should be clapping. You know, it's Thursday.
I'll still be in A&E.
I'll probably be on a train. Anyway, thank you all. I hope that's useful. And cheerio.
Bye-bye.
Bye.